Okay, good evening, ladies and gentlemen. Good evening. Good evening, ladies and gentlemen. My name's Gerald Fitzgibbon. I'm absolutely delighted to welcome you all to the Christie Hospital here in Manchester. Those of you who have joined in person and those of you from around the world who joined us via our live stream for this evening's event, Meet the Experts. A slight apology for those who have been waiting for the live stream. We're running about 10 minutes late, but you've got us now. So I'm deeply moved to see so many faces, both in person and online, united by a shared connection to Chordoma. So thank you for joining us this evening. As founder and chair of Chordoma UK, I'd like to extend my heartfelt thanks to the Christie Hospital for hosting us here and in their state-of-the-art Proton Beam Therapy Centre. For those who joined us earlier for the PBT facility tours, I hope you found it as inspiring as I do, seeing firsthand this remarkable technology that's changing the landscape for chordoma treatment in the UK. And thanks especially to those members of staff who gave us these guided tours, which was interesting and inspirational. I'd like to particularly thank Dr. Shermaine Pan, consultant clinical oncologist here at the Proton Beam Therapy Centre, who, when I approached her many months ago with the idea of Meet the Experts, without hesitation agreed to help pull this event together. Her tireless work made this whole thing possible. In addition, I must also thank Dave Glover, Victoria Taylor, Ruby Jensen and Claire Turnbull in the Christie Education Department, all of whom have dealt with the logistics for this evening. Every person involved has contributed to creating this unique opportunity for knowledge sharing and connection. Tonight is special because we brought together an extraordinary panel of experts across multiple disciplines, and we're so grateful to each of you on our panel for investing your valuable time in us and being here this evening. So let me very briefly introduce our experts. We have Professor Adrian Flanagan, consultant histopathologist and head of pathology at UCL Cancer Institute. This is from your left to over. We have Professor Omar Pathmanaban, consultant neurosurgeon, Salford Royal NHS Trust. Dr. Ramsey McFarlane, research group leader, Northwest Cancer Institute. Dr. Gillian Whitfield, consultant clinical oncologist, Christie NHS Foundation Trust. Charlotte Smith, specialist PBT radiographer. No, sorry. I've missed you out, sorry. Jumped. We'll start again. Andrew Wadeson, neurosurgical clinical nurse specialist at the Salford Royal Foundation Trust. Charlotte Smith, specialist PBT radiographer. And Peter Sandy, complementary therapist here at the PBT Centre and the Christie. And finally, Sylvie Leslie, a chordoma patient and Chordoma UK trustee. So there's our panel. This event embodies what Chordoma UK stands for, bringing together the best minds in chordoma care and patient community, ensuring that no one faces this rare cancer alone. Whether you're a patient, a family member, healthcare professional, or researcher, your presence here enriches our collective understanding and strengthens our community. Tonight you'll have the opportunity to hear from our distinguished panel of experts. We will then move on to a panel discussion with questions from both our in-person and virtual audiences. Your insights, questions, queries will help guide the discussion. Now, from a practical perspective, given we are working to a fairly tight time frame, may I ask that we show our appreciation to our experts once all presentations have concluded. And following the last session, we'll be serving further refreshments, giving our in-person attendees the chance to meet and speak with our experts in a more informal setting. So let's begin what I hope will be an informative and empowering evening for us all. First to speak this evening, Professor Adrian Flanagan. Adrian's a consultant histopathologist at the Royal National Orthopaedic Hospital. Adrian was elected as Professor of Musculoskeletal Pathology in 2004 and the Head of Research Department of Pathology at the UCL Cancer Institute in 2013. Professor Flanagan's research interests focus on reclassifying bone and soft tissue tumours using molecular signatures, which he then translates into clinical practice and uses for stratifying patients for treatment. Adrian was a co-lead of the International Cancer Genome Consortium Bone Tumour Project. She was awarded an OBE in 2017 for services to cancer research. Adrian Flanagan.
Thank you very much, Gerald, and thanks to the Manchester team who have made us feel very welcome. And it's a pleasure to meet the participants of this meeting. So, I'm over here really. So, next. Okay, so chordoma, I'm just going to go back a few years. And this chap is called Rudolf Virchow, and he was the kind of the grandfather of pathology. Here is his photograph from 1885, but in 1846, he was the first man to describe a chordoma. He was doing a post-mortem, and he found this jelly-like substance at the base of the skull, and he called it chordomata. And the research continued for many years, and other people got interested. And by 1900, there was quite a lot of development, and that research continues to this day, and has led to some changes in treatment and practice. Sylvie, there's also a picture up there, if that helps.
Yeah.
Sorry. So, Dr. Virchow thought that the chordoma arose in the. He found that other people found that chordomas always appeared to arise in the center of the body, along the vertebral, from the base of the skull right to the tailbone. He also found, looking down the microscope, and he was one of the first pathologists to use a microscope, that what a notochord looked like was what a chordoma looked like. And let me just go back now. So when we have a fetus, when the fetus is developed, they have a cord-like structure, a rod-like structure along the back. And with time, this rod-like structure disappears and actually forms these vertebral bodies from the base of the skull to the tailbone. And so putting all of this together, he thought that a chordoma arises from the notochord, from this structure which disappears in early fetal development. So all of us know that, many of us will know people who've had breast cancer or bone cancer or colorectal cancer. And then the tumor, we know it comes from the breast or the rectum or the colon. But it was very difficult to work out where a chordoma, why it developed, as opposed to breast cancer and colorectal cancer. So what we know is that in the embryonic, oh no, this is where I want to be. In the embryo, we have the rod-like structure, which disappears at about 6 to 16 weeks. But in the last 20 years, people have realized that occasionally, in very small numbers of people, little bits of notochord do not disappear. And they stay as remnants, as notochordal remnants, in the vertebral bodies, just where the chordomas arise. And it's thought that some of these notochordal remnants turn into chordoma. And we and others have developed evidence that this is the case. But actually, it is extraordinarily rare for this to happen. In most cases, those little tiny, maybe 5 or 10 cells will just sit there and never move, and nothing will change right through the whole of our lives. Many of us here, who, with or without chordoma, may have had these. But actually, if you're unlucky, for some reason, some of these will turn into chordoma. It's very slow in most cases, but we do see chordoma in very young children to quite an old age. But it's so extraordinarily rare, it's not really possible to screen and identify which patients may develop chordoma. As we know, chordoma only occurs in about 1 in 800,000 people, so it's not possible to screen for patients with chordoma. There are exceptions. these occur out of the blue, but occasionally in a very small number of families around the world, it is also does appear to run in families. But that is really exceptional. So for the 99% of patients, it's purely out of the blue, and children and offspring will not have a chordoma. And these tumours, when they just sit there, are called benign notochordal tumours. And this is what, just on a radiology, you see here at one of the cervical vertebra, you see there's a little bit of a pale area with a white area of bone around it, and that's what a benign notochordal tumour looks like. And this is the histology. And, well, most of you won't have been used to looking at the microscope, but that looks almost like fat. So it's very easy to miss. In most cases, it sits there, it's no problem. But this is what a chordoma looks like down the microscope. And you see it has some similar features, but is somewhat different. And so, this must be about somewhere about 15 years ago. This was the technology at the time, but with a colleague of mine, Chris Boshoff, we took 98 tumors and we put them on an array. And we had whatever we had in the freezer, and what we had was a chordoma. And we put 4 chordomas on the chip, and we found that these on the top are all the different tumors that we put on, but the 4 on the left are all chordomas. And the top bar here, you can see, is the gene brachyury, and all of these tumors express this gene called brachyury. And this was the only gene that was entirely specific to chordoma. Chordomas express other genes, but some of these genes are expressed in all of these different types of tumors. And that was how brachyury was discovered. And then we went on to develop a test where you can actually develop an antibody, and this antibody is now used for diagnosing chordoma if a tumor is taken out of somebody's body. Because actually sometimes it's difficult to diagnose chordoma looking down the microscope. It can look like chondrosarcoma, it can look like renal cell cancer, so making the correct diagnosis is very important. And this test is now routinely used. So then what did we do? Well, these are my 2 colleagues, but this is several years ago. They are both doctors, and they took 3 years out, and we arranged to collect patients' tumors. And these were donated to us by patients, and they grew these in the laboratory. And it was a labor of love. They collected all of these tumors, tons and tons of these cells. And it's very interesting to come out of the proton beam research lab, which you've just been shown, because it's these cell lines made by us, but other people around the world, that have been so invaluable for developing assays to test the effectiveness of the proton beam. Without patients donating their tissue for this type of research, we don't have the models to test the effectiveness of the proton beam therapy. This is another colleague, Lucia, who still is working with me, but she's, and this is what, when you get a tumor and you grow it in the test tube, these here are cells, and these are all chordoma cells. And we and others have made multiple of these, and they are now available for anybody who wants to work on chordoma around the world. Chordoma Foundation also funded some of this project. And these, we call these models of disease, because with these cell lines, and we want multiple cell lines because tumors can be slightly different, you can then test drugs on them. You can test radiotherapy on these cell lines. And therefore, that's why we're always so grateful to patients when they donate and allow their tissues to be used for research, because it's the research that will hopefully find a way forward. And so we now know that the chordomas, all of them express brachyury, and we wondered, well, what is brachyury? Does it play an important role? And what we did was, in technical terms, what we did was knock out brachyury in the genes, in these cells. And here is the chordoma cell line growing beautifully. And here, these two, we've knocked it out, and actually the cells just stop growing, which shows that actually brachyury is critical for these cells to grow. And I won't talk about this much longer, but I hope that my colleague, Ramsey McFarland, who works on brachyury and chordomas and other diseases, that he and many other people have now really identified as brachyury as the Achilles heel to target chordoma and its treatment. And with this, having identified these cell lines, I had a very nice young Egyptian PhD student who came over, and he added inhibitors to epidermal growth factor, and that shows that it blocked the growth of these cells. Again, we couldn't have done that without these cell lines that were kindly donated by patients. And actually, that then led to the afatinib trial, which was really the first chordoma, properly planned chordoma trial. And people have then gone on to develop, they still need a lot of optimization, they're not perfect, but people invested on brachyury vaccines, and people are trying to identify molecules that can inhibit brachyury so that you could treat chordoma. And one of the things very attractive about brachyury as a target is that it disappears, the expression of this gene disappears after birth, except in the testis, because these are very germ cells and they're growing fast. So actually, if one was able to target brachyury, there would be virtually no side effect. That one of the problems with all therapies, of course, is side effects, because they can hit other cells, healthy cells, but brachyury is not expressed in other cells. And so I would just like to emphasize the importance of research from the day of Virchow to today. And Ramsey will talk about the research in the biological setting. And of course, there are also a lot of developments in radiotherapy and also huge advances in surgery, which Omar will speak about. So for research, you need ideas, you need researchers, and you need huge commitment by those researchers. But I have to tell you, we're doing it for patients. And that's why we're always so very, very grateful when patients allow us to use their data. There's so many issues now with GDPR. I know it can be a bit of a pain when we ask you to give us consent. You have to fill in more forms, but that's the way it has to be. But we are extraordinarily grateful. Any data that we are ever given, or any tissue that we're given by patients, is all anonymized, so nobody would ever know from whom it comes. And of course, all this research, it's the only way that this basic research can then develop into clinical trials. So we've already had the afatinib trial, and of course, research also requires funding, and for that, I'm also extraordinarily grateful to Chordoma UK. And I would like to thank all of you here, and Jerry, Chordoma UK, thank you very much. Thank you.
Thank you, Adrienne. Professor Omar Pathbanaban is an internationally recognized expert in skull-base and pituitary surgery and is lead endoscopic neurosurgeon in the nationally commissioned NF2 and skull-based Proton multidisciplinary teams. It's a real mouthful, this. He is co-lead for skull-based surgery on the academic committee of the Society of British Neurological Surgeons, serves on the medical advisory committee of the Pituitary Foundation, is neurosurgical expert to the NHS England Proton Beam Therapy panel, and sits on accounts of the Royal Society of Medicine Clinical Neurosciences section. He is the group leader of the Surgical Neuro-Oncology Manchester Laboratory, and his research focuses on genes and immune cells in skull-based tumours. I hope I got that right, Omar. Come through. Omar.
Well, thank you very much for giving me the chance to be with you all this evening. We've had some feedback, I believe, from previous surgical talks at similar meetings, and the feedback was from previous attendees that they didn't want any surgical pictures or videos or anything like that. So I've stuck to brief, and you've not got anything to worry about in terms of gory pictures or anything like that. So nothing to worry about there. But it does make it a little bit difficult for a surgical talk to try and get away from those kind of things. So I've decided to try and speak about something which is actually a little bit of a thorny issue in chordoma care, which is around the fact that this is a very low volume, by which I mean there aren't very many cases, but very highly complex field of surgery. And there's been a huge amount of discussion with probably everybody, except for patients, I suspect, about how we best organise surgical care for chordoma, certainly in the UK, where we do have the advantage of the National Health Service, which potentially allows us to look at all forms of different organisational patterns of referrals and so on. So we're going to talk a little bit about that. And if anybody's particularly interested in it, then most of this is in the paper just published in BMJ Oncology, looking at these things in a UK cohort. So skull-based surgery, which is what I do most of the time, is particularly complex because of all the important structures that run through the base of the skull to the brain. And it really is the bit of no man's land that sits between the brain and the body. Okay, so it's where the blood supply comes from the heart to get up through the skull to the brain. It's where the cranial nerves, including your optic nerve and nerves which control movement of the eyes and vision, come through. It's where the nerves that come from your ears to allow you to hear get to your brain, and so on and so forth. So it really is a very busy intersection within the body, and very complex and very challenging to operate on because it's deeply seated, hidden amongst all of these critical structures. And this is just a picture of the skull base, which is not a surgical picture as instructed, but shows you without all of the structures, just the bony skull base, which is the area that we're interested in. Has this got a pointer on it? Pointer? No. Can you see? No. Okay, maybe I'll wander over here. So most of the chordomas in the skull base will occur in this area, the clivus, okay, or extending down to the craniocervical junction. Is there a pointer on there?
It's that one.
Ah, perfect. Thank you very much. Well, there we go. So I didn't press it for long enough. So they are occurring in this area, which is called the clivus, okay? Sometimes, more rarely, they come down to the craniocervical junction, and then even more rarely they can occur in other areas of the skull base, or they can move off to more lateral areas or affect the cavernous sinus, which is actually quite common, and that's an important blood-filled structure that also has your carotid artery in the main blood supply to the brain, and it has the nerves which control the opening and movement of your eyes within. And chordomas, for some reason, love the venous spaces, so they exist within what we call the interdural layer. That's the layer of the membrane that surrounds the brain that joins to form these blood-filled spaces called sinuses. And chordoma, macroscopically rather than under the microscope, but macroscopically when we're in there, tends to fill those venous spaces, which makes it again quite challenging because it's hidden away in spaces that we can't see, and if we access tend to bleed, which makes it more difficult again, which is part of the reason why often there is residual disease in surgically treated chordomas, because they're hidden away, they're insinuated in very important areas, and they're covered by these very delicate structures that we don't want to damage. But we know that the extent of surgery will improve. The greater the extent of surgery, the better your outcome, effectively. Okay, so we want to maximize the extent to which we remove these tumours, but taking into account the fact that we need to be very, very careful because of those important structures that it's sitting around. If we can't take it all out, then we want to try and make sure that we clear the tumour away from critical structures, most notably the optic nerves carrying vision from your eyes to your brain, and the brain stem. Okay, and that's because those are the structures which will limit the proton beam therapy that will be used otherwise if there's residual disease. So when we go into surgery then, we've got a number of goals. And we've got to remember that surgery, despite these hundreds of millions of pounds worth of investment in proton beam therapy, which is incredibly important, surgery remains the primary curative modality for chordoma. Okay, so if you can get a complete removal, that's the thing that's going to impact this disease most of all, as things stand now. So we want to try and get a complete removal if we can. Even better than that, potentially, we want to get even more than a complete removal, i.e. we want to remove some tissue around it, which is very unusual in chordoma because of those important structures that we've talked about. And therefore, we try to take it all out, but not at all costs. Okay, so our aim is to take it all out if we can, but not if we're going to cause serious harm or a serious impact on that patient's quality of life. Otherwise, what have we done that surgery for? When we're thinking about planning this, it's been quite common in the past for people to sort of trickle along over a number of years, 5 or even 10 years, having 3, 4, 5, 6 different operations and never sort of having a joined up pattern of care, which results in a compressed period of treatment onto proton beam therapy and then hopefully back on track with the rest of your lives and recovering from it. And so we want to get away from that and move to a single planned course of surgical treatment where we try and get everything done over a reasonably short period of time so that we can get patients treated and then back on track and hopefully back to work or doing things that they enjoy. We've got to be realistic in this disease in that we've said we don't take it all out at all costs, which means we don't want to harm people. Okay, we have to take some risk and sometimes it can't be avoided. But sometimes we have to accept that a subtotal, an incomplete removal, is the best way forward because it doesn't then lead to significant potential harms. And that's particularly where the next stage of proton beam therapy is even more important. And we'll hear more about that later because that disease has been left behind and needs to be controlled, if not cured. Okay, so if we're doing that, as we said before, we want to try and target the risk we take in surgery to those areas that most need to be cleared to allow high-dose proton beam therapy, namely the optic nerves and the brainstem. Okay, so in those areas, we will likely take a bit more risk with surgery to try and make sure that we optimize the resection. And then the last bit is tissue for diagnosis, and I should really add in there, and research, which, as we've heard, is critical. Okay, so that's the goals of our surgery. For the surgeon and for the teams looking after them and for patients, I think it's really important to be ambitious with this surgery. And I think we've suffered historically with a lack of ambition, a lack of surgical ambition when we take on these cases. And often, however sort of daunting these tumours are, you can see this one is completely invaginating into or compressing the brainstem. This one is compressing the brainstem but also the temporal lobe. And this one is straddling the upper part of the cervical spine as well as the skull base and compressing the brainstem. But in all of these cases, through careful planning and wonderful patients who've allowed us to do very major radical surgery, we've been able to clear all or nearly all of these tumours to allow them to move on to the next stage of their treatment and optimal long-term control of their disease. So I think whatever terrible picture you have at the beginning, I think it's important to remain hopeful and to be ambitious with what we are going to try and achieve with surgery. But to do that, you need the full range of what we call skull-based techniques. That's microsurgical techniques available to you. And that includes the traditional approaches, and I put that first, the open microsurgery. So although the majority of these cases are done with a telescope or an endoscope now, it's really important to be in a centre that's doing lots of open microsurgery for other conditions because it allows us to then turn those traditional techniques to chordoma when we need it, when it's better suited. And that includes to operate in areas like the cavernous sinus, that important blood-filled space we spoke about that's filled with blood, but also the nerves that control movement of your eyes and opening of the eyes, and the internal carotid artery, the chief blood supply to the brain. So The reason this is thorny and is discussed a lot at NHS England meetings, as well as in professional conferences in the UK, is that this is a very low volume disease. It's very rare. Okay, so if you take the whole population of the UK, it's less than 70 million people, and there are 30 neurosurgical units within the UK. Okay, and unlike most other sarcomas, the other group of tumours that chordomas belong to, almost all of those neurosurgical units will take on chordoma cases from time to time. Okay. For most other very rare tumours, these are limited to a subset of centres. Now that has positives and it has negatives. It means that patients have to travel long distances sometimes, which is really a problem sometimes if there are complications and you end up staying in hospital. It's not great for visiting and all those sorts of things. So there are downsides to it. But the positive side is it allows expertise to be concentrated in centres that are doing more cases, and that allows easier training of the next generation of surgeons who are going to take these cases on, and it allows the additional team members like Andrea and others to develop a strong base of experience to help patients through these very challenging times. So because of that, there has been a huge amount of discussion at NHS England in particular, and they have a program called LVHC, Low Volume High Complexity Surgery, and they've been through multiple different types of conditions, and the last previous iterations over the last sort of 3 years have included up to 19 different conditions, and the final iteration, that's come about in the last sort of year or so includes chordoma and chondrosarcoma, which is a completely different condition, but actually is very similar from the surgeon's perspective in the skull base. In the last final 3 conditions where they feel we still haven't got a good solution nationwide in terms of how we manage patient referrals and treatment with surgery specifically for this condition. So I think it's useful to involve all of you in this because these conversations are happening and people are trying to come up with what we think is the best way of doing this for everybody, but actually it's patients as well that need to tell us what you think on this matter. So, as things exist at the moment, and this relates to the data that I'll show you in a minute, the pathway is that all of the initial care for you once you've had your suspected diagnosis of a chordoma or a skull base chondrosarcoma, completely different diagnosis, but from a surgical perspective, sits in the same area and requires the same surgical skills to handle it, takes place in your local centre, or if your local centre decides to send you to another centre. Once the operation has taken place, then you'll have a post-operative scan done, and usually that will then be referred on to the National Proton Beam Therapy Panel, which sits within NHS England. And that will then be reviewed, and experts will look at that and give an opinion, and if everything looks suitable to continue with proton beam, then you will proceed to proton beam therapy. However, there's still a fairly high percentage of patients, and it's better now, I think, than it was when we first started, but that are not accepted at this point for proton beam therapy. And this is the group that we really need to think about, I think, because that means that we're not managing to get the optimal treatment pathway for these patients. Okay? And the reasons for this non-acceptance at the proton beam panel are usually that there is a substantial bulk of disease left behind that is felt to be amenable to further surgery, or that there is not sufficient clearance from the dose-limiting structures, that's the optic nerves and the brainstem, like we discussed before. And so at this point, if a patient is not able to proceed with protons, then that advice will go back to the local team, and the local team will then decide whether or not they feel that they can offer any further surgical management, or whether they feel they can refer the patient on somewhere else who might be able to help, or if they feel that this is not suitable for any further surgical intervention, which then means we might be looking at other forms of treatment like palliative radiotherapy. So the problem here is that, as you'll see in this data, this is the outcomes from that panel that look at happens when your case gets sent to the proton beam panel is that that varies the outcome from less than 30% to nearly 100%, depending on which unit you go to, which is a big problem because it means it's not equitable care or across the patch. But this is more complex than just one centre's better than the other, because these diseases and these tumours are very heterogeneous. Each case is different, and because it's low numbers, it's very difficult to draw direct comparison between one cohort and another. Okay, but if I told you that this centre, which happens to be Manchester, I'm not going to tell you about any of the others, has the highest number of cases, and this centre has the second highest number of cases, then a pattern starts to emerge that we're probably getting potentially better outcomes in higher volume centres. So we have looked at that in more detail. And that isn't 100% true in that there is a pattern for acceptance at proton beam, but there are the odd centre like this one that has relatively high numbers of cases but is not getting high numbers of patients through proton beam. So numbers coming through centres for surgery are not the entire story. It's not all about high numbers guaranteeing perfect outcomes, okay? But it potentially is part of the story. So we wanted to look at that in more detail, and we had a look at the first 75 patients who came through the proton beam centre here, because we have all of the information available to us, all the surgical notes, all the scans before and afterwards, all the pathology, etc. And within that initial cohort, it's a lot more now, but then there were 40 chordoma patients, and we bundled them together with anatomically similar chondrosarcomas, because this is a surgical question. It's not about the biology, which is totally different between these two, but our surgical aims and our surgical techniques are the same for these conditions, and therefore it's useful for us in order to get statistical analysis to increase the numbers in an otherwise rare pathology. And when we look at all the different factors that potentially could affect this, it boils down to the fact that the one thing that comes out as a significant predictor of your outcome there is the number of cases coming through the hospital where you're having your treatment. And so for each additional case, there's a very substantial jump in the potential chance of you getting a complete removal or near complete removal of your tumour. So I think I'll leave it there and just say that surgery remains as the primary curative modality for chordoma. It's an ultra-low volume, very small numbers of patients coming through most centres. Some centres operating on chordoma patients do less than one patient per year with this condition. And there is, I think now, evidence from the work that we've done here and others that there is some regional and centre variability in outcome, and that there is some evidence that you can get better tumour clearance and increased likelihood of being able to get through to the next stage of treatment with proton beam therapy if you are treated in a centre that has a higher surgical experience of managing chordoma. So I've left the final point here is that amongst all these conversations and the dozens of meetings that have happened at very high level in NHS England and everything else, I'm not sure that patients have been involved in this discussion. And therefore, I'll leave that question here to you, is that how do patients want care to be organised? And that's a genuine question, because it might be that people feel it's better to stay locally and have other mechanisms of oversight, or would patients prefer to have some degree of centralisation so that there are fewer centres and a higher surgical experience of managing this disease? Thank you very much.
Thank you, Omar. Dr. Ramsay McFarlane is Research Group Leader at the Northwest Cancer Research Institute, Bangor University. His group conducts research into the role played by human germline and embryological genes in the development and progression of a range of cancer types. He is also the CEO of a new company that has spun out of Bangor University and Cardiff University, Owen Oncology, which aims to develop new cancer specific therapies for rare and less common cancers. Ramsey McFarlane, thank you.
Check. Oh, yeah. Okay, thank you, Gerald. Thank you for giving me the opportunity to come and talk to you today, and thank you for making time to come and hear what we have to say. So as Gerald's just informed you, our research group is based, academic research group is based at Bangor University in North Wales, but we've recently spun out some of this work into the commercial setting for a new company, Owen Oncology, which is part now an affiliate of the Milner Therapeutic Institute at Cambridge University. We have to do this to ensure that we can get the magnitude of investment that's required for potentially developing therapeutics for cancers, particularly in this setting for chordoma. So I'm going to talk to you today about our work that we hope will generate a potential therapeutic for the treatment of chordoma. Okay, and I should say right at the start that this work didn't start in my research group. It started in Jane Wakeman's research group, who is also a research group leader at Bangor University, in collaboration with Andrea Brancal's group at Cardiff University. And Andrea is a professor of medicinal chemistry, and he's now moved his research group to Prague in Czechoslovakia, both of whom remain associated with the company. But it's important to understand that this is very much a sort of international effort, a team effort. The work that I'm going to describe to you today is very much built on the shoulders of giants, one of whom has talked earlier, Adrian Flanagan. And a great debt of gratitude should be owed to Adrian's team for the work that she's done recently and historically to enable us to provide a platform for us to try and develop therapeutics. And Adrian was also instrumental in supporting us and enabling us to move this project forward. In collaboration with Andrew and then Sandra Strauss, who is involved in clinical trials, has also been of great benefit to moving this project forward, and also Lucia Cotoni, who's within Adrian's group. You saw a photograph of Lucia earlier, who's based down in UCL, and I'm going to talk about some of the work we did in collaboration with their team. But also importantly, we've been working with the Structural Genome Consortium group at Oxford University, and particularly Joseph Noland. And at the end of the presentation, I'm going to present some data. Without the patients being involved and giving consent to use patient material, we couldn't have got the work to the stage that we got it now. And we couldn't have got the work to the point where we can hopefully get the investment, the magnitude of investment that's required to take this work forward for generating therapeutics. So I don't need to tell this audience about chordoma. It's a rare spinal cancer. And of course, as many of you know, it's resistant to most chemotherapies. So we've tried many attempts at repurposing pre-existing therapeutics to treat chordoma. Because of the nature of the disease, the slow, indolent way in which the cells grow, the biology of the cells, these cells are very resistant to many therapeutics that have been attempted. And as we've just heard then, there is no current effective therapeutic available on the market for the treatment of chordoma, and we rely on the excellent surgical intervention for the curative treatments of chordoma and radiotherapy. So, as I've alluded to, and Andrea's talked about, chordoma is an unusual cancer. The cells, the tumour makeup is quite unusual in its nature, and it might be this that then gives us its weakness, that this is its Achilles heel, that it's different from other cancer types, that it's got specific factors that enable us to target it. And to understand that, I'm going to talk a little bit about human development, and Adrian's already alluded to this, in terms of what is chordoma's weakness, and where does the chordoma originate from. So we can think of human development, and the analogy I like to sort of present for people who aren't familiar with sort of complex biological processes, you can think of it as building a new human being as similar to building a house. When you build a house, you need factors, you need bricks, you need cement, you need electrical wiring, you need architects, builders, concrete mixers. All those factors are needed to build a house. And when you build a new human being, you need lots of specific factors that are just needed to build that human being. Once you've built that human, you no longer need them. You turn them off. And if you leave them turned on, or they get switched on later in life, then you start to build things in the wrong way, and you get something totally dysfunctional. So, and this, coming back to the house analogy, shows you that ultimately that building will fail and be destroyed because you brought these factors back in when they weren't required. So we know then that there are a number of genes. So genes are the factors that your genome produces proteins to make functions within the cells, are switched on. They're those factors that are needed to grow a new human being. They then get turned off, which is all good, when you get after postpartum, once you've been born, and they're no longer required, they're never switched on again. However, we know in cancers then, a number of these genes can become reactivated and start to build new tissues, tumor tissue. So the house analogy again is that you've now switched on, you've brought the builders back in, you've brought the concrete mixers back in, you're starting to create something that's bad and having a detrimental effect on the body. But that potentially gives us a unique therapeutic opportunity, because those factors shouldn't be there. So we can identify they're there. We can see that there's a builder there laying bricks down, and that builder shouldn't be there. So that's a biomarker, biological marker to tell us someone has a tumor, or you can define a tumor type. And in the case of chordoma, Adrian's shown you this particular factor I'm going to talk about in a moment, brachyury, that indicates the presence of a tumor. But it also means we can specifically target those factors without targeting the rest of the healthy body, because those factors are unique to that tumor that's being built that shouldn't be built. So we can target them and hopefully have therapeutics that are going to hit the tumor and not hit the patient in detrimental ways. So where's the vulnerability for chordoma specifically? What is it about chordoma? Well, you're looking at a human developmental process in a little bit more detail here, and again, Adrian alluded to this. So we all start from a single cell. We start from a sperm cell, egg cell, come together, mum and dad, make a fertilized cell that we refer to as the zygote. The zygote then goes through multiple cell divisions where you get a ball of cells known as the morula, and those cells are relatively uniform in nature. But then at some point they start to change and say, well, right, I have to become a heart cell, a liver cell, a brain cell, a bone cell. And that occurs at a stage, largely and it gets initiated at a stage called gastrulation, where you start to get a more complex structure forming. And then those more complex structures get more complex again, and you start to get multiple tissues develop within the embryo. And it's this point at which this gene, TBXT, otherwise known as brachyury, gets switched on. So this is the gene that Adrian alluded to. And this is the gene, this is the factor that Adrian's group were responsible for driving and demonstrating a unique vulnerability in chordoma and with the clinical markers for chordoma. So this TBXT gene, you can think of it in the house building analogy again. You can think of it as a tool. So one of the builders needs a spanner. You can think of it as the spanner that's needed to help build the house. It's not needed for the rest of the time. It's just needed during this human developmental stage. And this stage of development, the gastrulation stage, you form a gastrula. And it's sort of a flat disc structure. This is an artist's representation of it here. And what you're looking at is cells of the gastrula start to move, migrate around this tissue. And cellular migration is a feature of cancers as well. And they start to change and they start to form the different tissue layers, lungs, skin cells, bone cells, brain cells. But one of the features that starts to occur is these cells will invaginate and then they start to form a tube-like structure here known as the notochord that Adrian showed you in the early embryo image that she put up earlier. And that notochord is a structure during human development that's just required during development, and then it gets turned off, it gets destroyed. So you can think of the notochord as a structure, a scaffold in the building analogy, that's required to build the spinal column. So once the spinal column is built, then that structure gets taken away, gets turned off. And as Adrian's alluded to then, it's been demonstrated or it's postulated that those cells from this developmental tissue reside somewhere in the spinal column, and at some point postpartum, through young infants through to older adults, those cells start to divide out of control. We don't really understand that process fully. But this potentially gives us a unique vulnerability in chordoma, because chordoma tumors are essentially large balls of relatively uniform cells that have lots of commonality to embryo cells. So unlike a lot of solid tumors where the cells within the tumor are very different, so killing them all is very difficult, within chordoma you have this uniformity of cells, and they all require this factor that Adrian's team was responsible for identifying, brachyury, TBXT. So if we can destroy TBXT, remember I said it was like a spanner that was required to keep the cells dividing. If we can stop that spanner working, then we can stop the cells dividing. And so Jane's group and Andrea Brown-Carl's group at Cardiff identified, they made an in silico structure of the protein brachyury, the spanner. They identified the structure of the spanner. And then it was later alluded to the human structure was identified fully from the Oxford group, Joseph Nolan's group. And what you're looking at here is a structure of a human protein of brachyury. So again, the spanner analogy, the blue bit you're looking at here, you can think of as the head of the spanner. Okay, that bit's rigid and that bit's required for the function of the protein. So the group in Cardiff then could use clever computational molecular biology where they can screen millions of small molecules to say which small molecule, which compound might fit into the space in the spanner to stop it working. Okay? And what they did was, out of screening 6 million compounds, we identified 3 different classes of compound illustrated by this molecule here, which isn't the real compound, of course. That's actually aspirin I put for illustration. But it shows that that compound can actually fit into the structure of brachyury, the spanner, and stop it working. So you've got a small molecule inhibitor that potentially can stop chordoma cells dividing. And the aim then, of course, is to see, can we get that small molecule into the chordoma material? And because the chordomas are made up of that highly uniform set of cells, they all require brachyury, they all require the spanner. Hopefully we can kill all chordoma cells. So I'm going to show you a little bit of data. I don't want to bore you with too many plots and data sets, but we've done a lot of work that goes behind the plots I'm going to show you. But I'll just walk you through this. The first thing we have to do with our compounds is show that they're not going to kill normal healthy cells. So we can culture normal healthy cells in the laboratory. These are normal human dermal fibroblasts, skin cells that we just culture. We can show our molecule, we refer to it as 7.1, and we have 2 versions of 7.1 here, one that we have synthesized through one route, one that we've synthesized through another route. We solubilize it in a compound called DMSO, and you can see here we're plotting the concentration of the compound against the viability of the cells, how alive the cells are. And you can see when we treat these normal fibroblasts with either DMSO or either version of our compound, they show no major killing. Okay? So there's no negative effects on normal healthy cells with our compound. We also put in a nasty toxin, sodium arsenite, to show that these cells can be killed. So that's just there as a control. We also ask the question then, do these compounds just kill any cancer cell? Because not all cancer cells require this spanner I'm talking about, brachyury. Okay? And this demonstrates that our compound doesn't kill just other cancer cell types where there's no brachyury present. This is an ovarian cancer cell type. However, when we look at chordoma, and we've looked at a number of chordoma cell lines, and I just show you one here. So these are the cultured chordoma cells that Adrian was alluding to that have been taken from tumor materials and cultured in the laboratory. Now what we find with 7.1 is that we get very clear loss of viability of the chordoma cells very specifically. We can then look at cell numbers, and we do lots of molecular analysis in the background here that I'm not showing you to demonstrate that we're getting target engagement and the proper hitting of the brachyury target. But we can seed a certain number of cells in a dish in the laboratory. If we don't treat them, or we just treat them with a control solute, you can see that they start to increase in number over time. So the cells will just carry on growing happily over time. These are chordoma cells. But again, when we treat them now with our compound, the cell numbers don't just stop growing, they reduce in number, and in fact what happens is they just disintegrate, and they don't come back over time. So that's telling us our compounds are hitting the chordoma cells, and the chordoma cells over time aren't getting resistant and regrowing. So I'll close just with one final slide, because I think this illustrates a really critical point. What happens with patient material? And this is where patient engagement and patients allowing ourselves and clinicians to have access to the patient material is of fundamental importance. And it was also important for this project at the time to note the role that Chordoma UK played, because chordoma is a rare disease, so trying to get investment to actually study and research chordoma is very, very difficult. And we were at the stage that we needed a little bit more investment to enable the teams down in UCL, Adrian's group with Lucia Cottoni, to actually do the experiments in London. So we sent one of our team members down to London, and they did the work that I'm going to show you. And as I've mentioned, and this was through the use of patient material from 2 patients. So what took place down in London, there was a surgical resection taking place from 2 patients. What happened was that you put the tumour material, this has lost its direction, the tumour material into 2 plastic wells. So you're looking here down onto 2 plastic wells. that have a solute in them where 2 pieces of patient material have been placed into those wells. And you can see there quite clearly the tumour material holding its structure. This is after 8 hours incubation just in a solute. However, now when we add our compound, what happens overnight, it was an 8-hour incubation, is this tumour material just simply disintegrated. The guys got on the phone and said, "You're not going to believe this." And so it's quite a dramatic visual, qualitative result of the effect of the compounds that we've developed. Okay, and in the background, of course, then we do lots of molecular analysis on these cells as well from patients to demonstrate that we're getting efficacy and hitting that target that we believe that we're hitting. So I'll leave it there because I believe this demonstrates that there is hope. It's not just our group and our commercial setting now that are trying to identify inhibitors of brachyury. There's efforts going around on worldwide, so there are other commercial settings as well where people are trying to target, with some success, brachyury for the treatment of chordoma and potentially other cancers. So I'll stop there and thank the people who actually did some of the experimental work, but also, as I mentioned, very importantly, Chordoma UK, because the financial assistance they gave us at a crucial time was instrumental in enabling us to take this work forward. And again, thanks to the patients who enabled us to use their material. Thank you.
Thanks, Ramsey. Really interesting. Dr. Julian Whitfield, consultant clinical oncologist at Christie NHS Foundation Trust. Julian graduated from St Bartholomew's and the Royal London School of Medicine and Dentistry in 1998, trained in London and East Anglia, and became a specialist registrar in clinical oncology in 2022. She gained her FRCR in 2005, completed a PhD in image-guided radiotherapy in Manchester, and joined the Christie in 2011, where she led the development of the intracranial SRS service. Dr. Whitfield has driven radiotherapy improvements, including PBT planning, and has provided national leadership in e-learning, quality indicators, and radiotherapy guidelines. She's a frequent speaker and contributor to textbooks on CNS tumour radiotherapy. Dr. Julian Whitfield.
It works. Okay, good. So I found it quite difficult to know what level to pitch this. So we'll go for it, and you can ask me extra questions and things if there's things I haven't covered that you want to talk about. If I can make this work. There we go. So I thought, like some of the other speakers, I'll give you a little bit of background of history. And the first thoughts of using proton therapy for medical treatments were in 1946, when Robert Wilson, who was professor of physics at Harvard, and who after the war had been involved in the design of the Harvard cyclotron laboratory, thought that we could use the Bragg peak of protons, which I'll come to in a moment, for radiotherapy type treatments. So that's where it sort of started. And this shows what we call the proton Bragg peak, which you may or may not have read about. I'm not sure whether people will be familiar with this, but what this is trying to show for conventional radiotherapy that we call photons, which is this magenta, compared to proton therapy, which is this, oops, it's very hard to control this red thing, how the dose deposited changes with depths in the tissue. So what you've got to imagine here is that the beam is coming in from the left of the patient, and this is as we get deeper into the patient. So what happens with a conventional radiotherapy beam is at the skin surface, it already deposits a certain dose of radiotherapy, and about 2 centimetres below the skin surface, it deposits the highest dose. And then as it travels deeper in the patient, there's a decreasing dose all the way, and in fact, it'll go out the other side of the patient, having given some dose all the way through. Whereas with protons, which are different, they're heavy charged particles, whereas photons are X-rays, they don't really have any sort of mass or weight. But with protons, there will be some dose at the skin surface, but there's actually more dose as you go at depth into the tissue. And as this happens, the proton is slowing down, and as it slows down, the positive charge means it causes more and more interaction with the tissues until it nearly comes to rest. And just before it comes to rest, there's a big surge in the amount of dose it deposits. And then after that, there's pretty much nothing. So normally we're in a situation where the tumour, you're trying to treat is at some depth. So, in this one, the situation would generally be that the tumour you're trying to treat is in this kind of area. So you don't really want to give too much dose on the way in. You want most of the dose to be near where you're trying to treat. And obviously the proton therapy looks like it might be more suitable for that than the conventional radiotherapy. And the Bragg peak was named after not this Sir Lawrence Bragg, but his father, Sir William Henry Bragg, who actually first described the Bragg peak in 1903, but not with protons. He described it with alpha particles, which are the product of radioactive decay of radium, and they're like a helium nucleus. So you get the same thing with alpha particles, and he described it in 1903. So that's why it was named the Bragg peak. So this is another way of perhaps looking at what we're trying to do with proton therapy and comparing it with conventional radiotherapy. So again, if you can imagine, the beam is coming in from the left, we're trying to irradiate some tumour, and maybe there's some normal tissue beyond it, which could be your brainstem, it could be your nerves of vision that we're trying to spare. So with conventional radiotherapy, the dose decreases as we go at depth, and you see that this blue colour is getting lighter as the dose is getting less. But we do irradiate the tumour, and we still give dose to the normal tissue beyond. Whereas with protons, we can arrange it that the proton beam stops just beyond the tumour, just with enough margin that we specify, so that we can completely spare this normal tissue beyond. And you can see here actually the darkest bit, the highest dose, is just here at the far edge of the beam. So that in some ways is more advantageous to us when we're trying to irradiate the tumour and spare other tissues. So there's two sort of main groups of patients where this is relevant, because overall in the UK only about 1% of all radiotherapy is given with protons. So how do we select the 1% that are most likely to benefit? Well, there's two main groups. So the first group in children and young adults is when we're trying to reduce the side effects. So children and young adults are particularly vulnerable to some of the side effects. You know, if you're treated when you're 2 or 4 or 10 and you're cured, you then have, maybe 80 years to develop some of the long-term consequences of radiotherapy. So in children and young adults, what we're particularly trying to do is benefit from that sparing of normal tissues. So we only irradiate the tissue on the way in, the tissue at the tumour, and then we manage to stop the beam and give nothing beyond that. So there's less radiation in total, and therefore fewer side effects, and particularly fewer long-term side effects. So that's one group. The other group includes things like chordomas, and that's tumours where we're trying to give a very high dose to the tumour. So chordomas aren't particularly sensitive to radiotherapy compared to other tumours. We need to give a higher dose than we give for most tumours, but they often sit next to sensitive normal tissues that can't actually tolerate that high dose, like the brainstem that Omar already mentioned, like the nerves of vision. So in this case, we're using the fact that we can stop the beam and spare the normal tissues beyond to try and get that high dose in that we need to give next to something that can't really tolerate that high dose. And people often ask, is proton treatment new then? That's one of the very common things that patients ask. Is it new then? How long has it been around? Can I trust it? Well, it's not new, although I do think that proton therapy in 1954 probably looked rather different to now. In 1954, there were no CT scanners, there were no MRI scanners. They could do X-rays to figure out where to target the beam. Of course, there were no computers to do the kind of complex dose calculation we can do today. So I don't think I much would have liked proton therapy in 1954, but it was there. Started at the Lawrence Berkeley Radiation Laboratory, so it was a lab, a research lab. And then it started at Harvard Cyclotron Laboratory in Boston in the early 60s, and they started treating chordomas and chondrosarcomas, the other tumours that Omar mentioned. In 1984, we had the first proton therapy in Europe, and that was at the Paul Scherrer Institute in Switzerland, but that was a very low energy proton facility that couldn't treat tumours at great depth. It could only go to the depth needed to treat eye tumours. In 1989, we had the first proton facility in the UK at Clatterbridge in Liverpool, but again, a low energy facility that could treat eye tumours but couldn't treat tumours at great depth. And then the first hospital-based high energy facility that could treat tumours at depth was in California at Loma Linda in 1990. And Loma Linda, I don't know if you might know, but it's a community where one of the places in the world where people are particularly long-lived. I think it's probably quite a big elderly population, it's quite a wealthy part of the country, and that's where the first sort of high-energy proton facility outside a research facility was built. So you could say that proton therapy in something like the current form has been going at least since the 1990s. But the other innovation that came was in 1996, and this was when the current state-of-the-art spot scanning therapy was invented at the Paul Scherrer Institute in Switzerland. And up until 1996, with the spot scanning, or pencil beam scanning as we also call it, up until that time, patients were treated with proton therapy with a broad beam, broad enough to cover the whole tumour, the width of the tumour, just as was the case, and is still the case, in conventional radiotherapy, that you treat the whole width of the tumour within, that sort of aperture of the beam, if you like. But in 1996, what the Paul Scherrer Institute invented was this means of treating with a very narrow proton beam that we call a pencil beam. And the way that works, and there are animations if you look on the web, but I didn't bring you on tonight, it would take too long, oops. But the way that worked is that you have this narrow beam and you scan in a grid through the tumour that you need to irradiate. And then that goes to a certain depth, and then you reduce the energy, which means the beam doesn't go quite so deep, and you scan the next layer at that lower energy. And then you reduce the energy again, and you scan the next layer. And that way you scan all your way through the tumour. And that's how all the modern radiotherapy facilities treat. So, for example, here at UCLH, we only have spot scanning treatment. We don't have the older types of treatments. The older type was called passive scattering. So a little bit about when proton therapy came to the UK. So this started back in 2007 when the National Radiotherapy Advisory Group reported to government ministers on developing a world-class radiotherapy service in England. And at that time, they identified that proton therapy, which was still obviously quite young at that time, was something that the UK ought to be embracing and thinking about developing. So that was 2007. And just the next year, in 2008, the NHS Proton Overseas programme started. So we started to send patients overseas to primarily the Paul Scherrer Institute in Switzerland, Jacksonville in Florida, and Oklahoma City in Oklahoma. And you can see that initially, here at the beginning, the numbers were very low. This was the year it started, 25, but it gradually increased, reaching about 150 by 2014 and over 200. Over 200 by 2016. But it was still very restricted at this point. It was mainly children going overseas for treatment, plus actually patients with complex tumours, chordomas, chondrosarcomas, skull-based tumours and spinal tumours needing high doses next to spinal cord, next to brainstem, nerves of vision, etc. So chordomas were among the group that were funded for overseas treatment right from the beginning. So all that time, patients have been going abroad for chordoma treatment. And then in 2015, the government gave its final full business case approval for the 2 proton centres to be built, one in Manchester, one in University College London, a £250 million capital investment. And they were both given that approval at the same time. The one in Manchester opened in December 2018 and the London one in December 2021. And the reason for that 3-year delay was just the complexity of building in London, building on prime central London land, wanting to use every square metre to best advantage. So digging about 6 stories down to within a couple of metres of the tube lines, and all the complexities that go with that. Whereas in Manchester, we haven't had to go 6 stories down, we've just gone up, much simpler. So this just shows you what's happened with the numbers since. So the numbers now, this is actually predicted for this year, but last year we can see 2023, it was about 600 patients received proton therapy, and this year we're on target for it to be over 750. And you can see there's a split where, about half of it's adults, and of the rest, it's more children than teenagers and young adults. So it's still, a minority of all radiotherapy in the UK, but it is rising, and we're not yet at capacity in the 2 proton centres. So a few words then about chordomas. So as I said, chordomas have been treated in the UK Overseas Programme right from the beginning. And last year we published the first sort of outcomes of that group of patients. And chordomas were actually the second largest group of patients travelling overseas after a particular tumour type in children called ependymoma. So a big group, and 177 patients were analysed in this group last year. Overall survival, so the number of patients surviving in that group was 89.3%, and the tumour was controlled in 81.8% after about 3 to 4 years of follow-up. So we are really looking forward to being able to publish the UK NHS figures, which, the indications are that they will be better than that, but we haven't published yet, and we're just sort of verifying all the data and making sure that we report it accurately, and that, when we get that paper out, it will be properly representative. This is about side effects in chordomas treated in the overseas programme, and is just reporting the severe toxicity, not the mild side effects. So we call that grade 3, 4 and 5 toxicity. So grade 3 toxicity, as you can see there, is a severe or medically significant but not immediately life-threatening side effect of treatment. You might need to be hospitalised or stay longer in hospital, or it might cause disability or limit your ability to look after yourself. So of the patients treated, we had 23 patients with grade 3 toxicity, and that was about 16% of the total group for whom there was data available. Actually, you can see in total the patients there is 120, because some of the patients we didn't have all the follow-up data, because we're reliant on other centres where these patients have been treated sending us the data back. But 16% had severe side effect, many of which would be reversible. In terms of grade 4 toxicity, which is life-threatening toxicities or needing urgent intervention, that was just under 2%, 1.7%. And in terms of fatal side effects, that was 2.5%. Now, it might be interesting to note what that grade 4 toxicity includes. So that serious toxicity, which is in just under 2% of patients, that includes going unilaterally deaf, and it also includes a patient with visual loss. All right, but you know, lots of people will have some hearing loss and wouldn't necessarily think of that as a severe toxicity, but depending on the grade of it, that is considered a severe toxicity. The patients who died were 2 patients with a stroke at just over 6 and 7 years follow-up, and 1 patient with what we call necrosis, so radiation-induced damage. I think that was probably brainstem damage in that patient. So coming to the Christie treated chordomas, to date we've treated 151 chordomas, which is actually a respectable size series. It's the same size series that the Paul Scherrer Institute has reported from their experience over a longer period. We don't have as much follow-up as they have so far. They reported with about 7 years follow-up, which obviously we wouldn't have yet because we've only been open 5 years, so on average we might have 2.5 years follow-up. But of those 151 chordomas, 62 were in the skull base and 89 were in the spine or in the sacrum, the bottom of the spine. You can see there by date of referral, obviously we only started in December 2018, so hardly any then, but we peaked at just over 45 in 2020, and the numbers have fallen off a bit since, and that's because of University College London opening. So for the first 3 years, we were the only UK site and we were still treating all the chordomas, but obviously now it's split. And by site and age, as well as saying, you know, that 62 were base of skull, I can say that 3 of those were children, and of the 89 that were spinal, 3 of those were children, but almost all of them were adults. But we do have some chordomas in children as young as sort of 3 and 4 years of age. In terms of surgery, I won't dwell on this too long because Omar's talked about it, but for skull-based chordoma, what's really important for us from the proton therapy is that we get tumour at least 3 millimetres away from the brainstem and at least 5 millimetres away from the nerves of vision. If we don't achieve this, we won't get the desired dose into the tumour. We do also know from published data that you do better if there's less than 25 cc's of chordoma left. Personally, we would consider that a massive amount of tumour, and we wouldn't like to treat anybody with that amount of tumour. There is also good published evidence that you do better if there's actually no visible tumour. So if all the macroscopic visible tumour has been left and all we're dealing with is microscopic disease. But we will always prioritise making safe the treatment to the normal tissues, so to your brainstem, to your nerves of vision. So that will mean that if there is tumour too close to those structures, we will give less dose to the tumour. We will not overdose your brainstem or your nerves of vision in order to better treat the tumour. The only exception to that is, where we have some tumour near one of the nerves of vision, particularly if that's the only bit of tumour that we're struggling to treat. With the patient's agreement, we might accept a higher risk of blinding them in one eye, which would never be 100% risk, but it might be, say, a 20% risk, whereas normally we might aim for a 1 or 2% risk. But we would only ever do that to one eye. We would never do that bilaterally. For spinal chordoma, surgery is a little bit different. It's not particularly my area, but what we can say is for spinal chordoma, if possible, when they're operable, they'll try and do what's called an en bloc resection, where you try and take the whole tumour without opening it up, without spilling it in adjacent tissues, and with a margin of normal tissue around it, which may be a very small margin, but that would usually be the aim. If possible, we try and avoid placing too much metalwork in the spine. The metalwork makes it difficult to get the proton beams in, difficult to know exactly what dose we're giving near the proton, near the metalwork, and it also makes it actually difficult to see what we're treating, because the MRI scans get really sort of full of artifact and difficult to interpret with metalwork. So often in the spine we'll use constructs with something called PEEK. You might have screws that have a little bit of metal on the surface so that we can see them are predominantly not metallic. And in low down in the spine, in the sacrum, surgery can be quite difficult. Low down in the spine, in some cases, if you operate, you may cause the patient lifelong mobility problems or double incontinence. So some of those patients will be treated without surgery, but what we don't yet know long term is if their outcomes are quite as good as if you're able to have surgery and have the tumour completely removed. And I just got 3 quick examples. I hope I'm not too much over time. This is just to show you some examples of the type of thing we might be treating. So this first example was a patient with a large chordoma in the central skull base. So that red contour is the chordoma before surgery. So it's sitting just in front of your brainstem here. It's going into the nasal cavity. Here in a side-on view, you can see this is your brainstem, this is your spinal cord, and all of this thing outlined in red is your tumour. So this is what the proton plan looks like. The red is the high dose of radiation, the blue is the low dose. So this is a typical beam arrangement we have with 4 beams coming in, 1 here, 1 here, 1 coming in here, and 1 coming in here. So we have 4 beams. They all give some dose on the way in, that blue low dose on the tissues on the way in, but we arrange it so they overlap. And where they overlap, that bit where the tumour is sees all 4 beams and gets a higher dose. So as well as using that Bragg peak and the fact that there's more dose at the end of the range, we also use the overlap to make sure that we give the high dose in the tumour area. Here's another example of a large tumour sitting right at the base of the skull. So you can see in this side-on view, the brainstem is all the way here, carries on to here, and then we're at the spinal cord, and this sits right at the junction of the brain and the spinal cord. Big tumour, quite difficult in this location because it tends to make the head unstable on the spine. Usually, eventually, these will need metal work, if not initially at the time of surgery. And it's also very difficult for us from a radiotherapy point of view. So you can see here, the high dose wraps all the way round. It's hard to control this thing. It wraps all the way round this little structure here, which is the poor brainstem sitting in the middle of it. You can see that in the side-on view here as well. Here's the here's the high dose, the red dose to the tumour, right in front of the brainstem and the spinal cord. So it's really important when we position that patient for treatment each day that it's done incredibly accurately. to, millimetre precision, because if that patient is not positioned accurately, that high dose will land in the spinal cord and the brainstem, not in the tumour where we want it. So you can see why it's really important that, if possible, we have a gap between what we're trying to treat and the brainstem or the tumour. And then the last example was just to show you that there are some small chordomas. This would be an example of a small one that you see there in the red contour again before surgery, much smaller treatment. And this was to show you finally that we do sometimes see these areas of what we call radiation necrosis, radiation damage. So this is a patient 2 years after treatment with on scan some imaging changes there. That's not tumour. We often get asked, is this tumour, by the centres who've referred us? But this occurring within the brain substance, this isn't how chordoma reoccurs, but it is the typical appearance of a bit of radiation damage. That's often completely asymptomatic. It may clear away again on subsequent follow-up scans, but occasionally it can cause headaches or, if you're unlucky, seizures. But that's because we're needing to give that high dose right next to that bit of brain, and sometimes we do get those bits of damage. It would be easy to avoid by dropping the dose, but then we would be less likely to cure your tumour. So that's all from me. Hope that was informative, but happy to take some questions at the end.
Thank you, Gillian. Andrew Wadeson is a neurosurgical clinical nurse specialist. Andrew, an RGN since 2001, joined the skull-based team in 2009, where she established a new service and developed expertise in managing skull-based tumours, including chordoma. She runs nurse-led clinics to provide perioperative counselling and manage post-treatment symptoms, and is level 2 psychology trained to offer emotional and cognitive care. Andrew also participates in local and national boards, including patient charities and research groups, and has contributed to an NHS England steering group to set quality standards for skull-based pathology patients, as well as being involved in local audit and research. Andre.
Thank you. So I'm going to talk about the perioperative care of chordoma patients, so from diagnosis and through the surgical treatment pathway. As I've just been introduced, I'm one of the specialist nurses in the Salford group here in Manchester. I only deal with skull-based chordomas, so predominantly we're going to be talking about the skull-based care of patients today. I know some patients here have been under my care in Manchester, but I assume most patients in other units have access to a clinical nurse specialist, or I certainly hope they do. The role of the clinical nurse specialist is really all-encompassing, from diagnosis through to discharge. And essentially what we're trying to do with patients is coordinate the pathway and make sure that patients don't have to take on the burden of knowing what comes next. This clinical nurse specialist is a point of contact and acts as an expert clinician to patients. So when questions arise or when symptoms arise, they've got somebody who knows this disease and somebody they can contact directly. We also act as a port of education. So for patients, for GPs who may never come across this type of pathology, and for ward nurses, ward therapists and junior doctors who again may only find themselves looking after 1 or 2 chordoma patients in their time. While patients are on the wards, we also do daily ward reviews, so patients often have their surgery and need looking after on a high dependency type ward in the first few days, and then they go to a neurosurgical ward. And we'll guide patients and guide the clinicians in terms of symptom management. Once patients have been discharged, we'll also offer clinic reviews, whether that be ad hoc or whether that be in terms of set clinic times. We're also involved in other aspects of patient care, so the non-clinical aspects, so audit and research, working with local groups and national groups to make sure that benchmarks are set to optimise patients' outcomes. Management of patients with chordoma in the surgical pathway needs to be a multidisciplinary approach. You've already heard from surgeons and the oncologists, but really there are other multidisciplinary experts behind the scenes. So you have clinical nurse specialists, you might have the psychologists, the physiotherapists, the endocrinologists, the ear, nose and throat doctors. It's really a multidisciplinary and holistic approach. So patients will require symptom management in the first instance before treatment. A lot of patients tend to present with symptoms, usually relating to double vision, and it's often down to the clinical nurse specialist to try and navigate those pathways and make sure patients are referred into the appropriate specialists, both pre-operatively and post-operatively. So pre-operative considerations, as well as symptom control, so pain, visual disturbances, swallowing problems. There's also the psychological well-being. I'm sure many of you know how daunting it can be to be diagnosed with a tumour, especially one that's very rare where information is lacking. So in terms of the level 2 psychology that myself and my colleague Helen are trained in, we offer counselling, we offer education sessions to make sure that we address needs and answer any questions. We offer counselling and support, and we also refer patients into the psychology services at appropriate times. We also ensure that the pathway is timely, so from start to finish we're pushing to make sure that patients are seen in clinic, that they're listed for surgery, and that they're offered appropriate input by the therapist and the referral to the specialists who manage the secondary needs of these patients. And also make sure the appropriate investigations are ordered, so patients need hearing tests pre-operatively, they might need visual assessments, they might need endocrine baseline testing. While patients are on the ward, they're usually managed initially in the critical care or high care bed. A lot of our patients will have endonasal route for the approach for their surgery, although some patients will have a cranial route. And often, again, I'm sure many of you here have experienced this, with the endonasal route to get to the skull base chordomas, it's a very traumatic and uncomfortable approach. So nasal packing is used, there's a lot of discomfort, a lot of dryness, patients aren't able to breathe through the nose. So a lot of the things that we do as clinical nurse specialists are managing those types of symptoms. Often patients might have a lumbar drain, especially if they've had a cerebrospinal fluid leak. Cerebrospinal fluid is the water that bathes the brain and the spine. It's one of the common side effects that can happen after this type of surgery. We've talked about symptom control, but whilst patients are inpatients, we tend to ensure they're on the appropriate pain management, anti-sickness medications and antibiotics, as well as address any endocrine issues that they might have and get the endocrinologist involved, especially if they're having difficulties with secondary issues such as SIADH. And before patients go home, we always see them to talk about discharge to make sure that they're well informed as to what to expect, what normal symptoms may arise, what might happen in terms of complications and who they may need to contact, driving and getting back to work. We also ensure we refer to the appropriate therapists. So a lot of our patients might have difficulty with swallowing or voice, they might have difficulty with movement or pain, they might also require adaptation at home, they might require care. So we do all the referrals to the appropriate therapists and specialisms. Once patients are through the first few weeks, there's long-term management of these patients. So we tend to manage these patients through community teams. Again, we talk about seeing patients in clinic. We have an ad hoc clinic where patients can come and see us and try and identify any problems early. So if they develop a meningitis, for instance, we're seeing them in nurse-led clinics to try and avoid A&E admissions. And we're also referring on to the community specialists. We act as a link between the surgical team and the proton beam therapy team, so we ensure again that that referral and that pathway is timely. In terms of ongoing care, so further down the line, patients will be transferred over to the proton beam therapy key workers, and Charlotte's coming up next. I'm sure she'll talk about her role. Ongoing psychological care, so patients often have difficulties following this type of surgery in terms of emotions, mood, fear, anxiety, distress, getting back to the normal swings of life, getting back to work, getting back to socialising. So if we can't manage it ourselves, we refer into psychology, and we often do group sessions with patients or double up with the psychologist to do joint appointments to make sure patients' psychological needs are addressed. Quality of life is quite a big part of what we do. We try and improve quality of life by addressing symptoms and by addressing the emotional needs. There's very little out there in terms of the research in quality of life of chordoma patients, and it's an area that we're trying to address at Salford. In terms of recurrence, we know that patients are at risk of recurrence, so we make sure that MR scans and follow-ups are timely and that patients are put through our MDT as soon as possible. And we try and allay fears about recurrence. We also know that some patients will sadly succumb to these tumours, so palliative care is a part of our role. That is becoming less and less, thankfully, as we're seeing more dynamic surgeries and more experimental treatments. We've already talked about genomics, and both Helen and I are helping to coordinate the pathway for our patients to more readily be treated and referred to the genomics service for testing of their tumours. We also get involved in the research, so in terms of coordinating patients to give their tumour samples and to give their consent to be involved in research. Helen and I are usually involved in that side of managing patients. We never discharge a patient, so patients tend to stay under us for a very long time. I've seen some faces that I've not seen for quite some time here today, and it's lovely to see people. But we never discharge patients, so our group is growing. We're learning a lot more about our patients and their long-term needs. It's a pleasure to be a clinical nurse specialist for patients with chordoma at Salford. And yeah, we are here to basically coordinate all of the care for patients from start to finish. That's me. Thank you.
Andrew, thank you so much indeed. Charlotte Smith is up next, a specialist PBT radiographer. Charlotte qualified as a therapeutic radiographer in 2006 and started in her specialist role in 2011. She has since gained multiple qualifications, including Masters in Advanced Practice, Clinical Examination Skills and Non-Medical Prescribing. Charlotte works at an advanced level, running radiographer-led on treatment clinics and supporting her medical colleagues and patients undergoing radiation therapy for central nervous system and base of skull tumours. Charlotte.
Lovely. Hello everybody, it's nice to see everyone, and to those of you online, hello and welcome. So I've been asked today to talk to you about the pathway for patients that get referred to us for proton treatment and the support that we can offer to patients whilst they are here with us. And I hope this is the right one. Yes, lovely. This is a very busy slide, so I'm not going to go through each individual section, but this basically is an overview of how the pathway works for proton referrals. So as Omar referred to earlier, as your local team discusses proton therapy with you, and if you are agreeable to being referred for it, your local team will then send your information over to us, and we will discuss you in our local MDT. We have all the local team in that MDT, so we have Omar and his team, we have Jill and the clinical oncologist, we have myself and the key worker team and the pre-treatment team and lots of physicists and lots of people are involved in that discussion, and we will look through all the images, and if we agree with the local team that protons is the right treatment for you, then we will formally accept you for treatment, and that's really at the point at which I and my team will then step in. So we will then contact you to invite you to come over to Manchester, to come and meet us and to go through what we call the assessment visit. I'll go over this in more detail on my next slide, but this involves coming to Manchester, having a series of preparation appointments with us. You then return home for a period of time whilst the very clever physicists and doctors and our planners make a plan bespoke to yourself as an individual, and then we will be in touch to call you back to start the treatment a couple of weeks later. You then start the treatment and you're with us for a not insignificant amount of time, and we will look after you during that time period. You then finish your treatment and we refer you back to your local team to continue with your onward care. So what's actually involved in the assessment visit? Well, first of all, you have to get here. So the NHS will fund accommodation for you whilst you're here, and I'll go on to that shortly. But unfortunately, it doesn't stretch to travel to and from the centres, so that is a responsibility of yourselves to get here. Your local teams can organise transport, hospital transport for you if you require, but otherwise it is up to yourself to get here. So once you're here, we have a consultation with you. So you'll meet the clinical oncologist you're allocated to, and either myself or my colleague. At the moment it's Kate that I work with, but there's Amy as well who's on maternity leave. So one of us will be allocated to you as a named point of contact. So we will meet you in the consultation. We'll have a chat to you, we'll get to know you, we'll go through your history, and then we will go through the rationale for you coming to Manchester and to have the proton therapy. So just like Dr. Whitfield's already described, we'll go through why protons is beneficial for you, we'll go through the risks, the benefits, the side effects, and if all of that sounds like you're agreeable to proceeding, then we'll ask you to sign multiple consent forms, and once we have got your signature on those forms, we can then proceed on to the next stage. The first of which is having the mask made. So it looks not dissimilar to the one that's on the screen right now. And for those of you that have been through the treatment or been through and seen the setup today, you'll know that the mask is bespoke and individual to you. It's made, it starts off as a flat sheet of plastic that we warm up in our oven, and it's moulded to your face as in your individual face. So once we've got the mask made and you're reasonably comfortable with it, now obviously we need it to be tight because we need to keep you super still so we don't have any movement. So we realise this can be quite claustrophobic for some patients, and we have a wonderful colleague called Pete who's going to be following after me, who works wonders for people with anxiety or claustrophobic. So once we've had your mask made, we then proceed on to have a CT scan, which is the, where's the pointer, is it that one? Yes, lovely. Oh, Jill, you're not wrong, it is tricky. So this one's the CT scan, and then we also need you to have an MRI scan as well, which is the one down here. So yeah, so we need those three things in order to plan your radiation treatment. The MRI scan is done with an injection of some contrast dye, so we do need to pop a cannula into your hand or your arm to administer that contrast. So once we've gone through those procedures with you, we will then check through the scans to make sure that we've got everything that we need. And once we're happy that we've got everything, we will then ring you and let you know that you are free to return home. It normally takes us a couple of days to do this assessment visit, so you're normally here in Manchester for 2, 3, maybe 4 days. But then after you've done those appointments, you then return back home and our clever physics team crack on and get on with planning your treatment. So when we actually call you to say, yeah, we're sorted, your plan's ready, we're ready for you to come back to Manchester, you travel back to Manchester and you check back into our accommodation, and then you come to see us as an outpatient to receive your radiotherapy treatment. It's incredibly rare for us to actually have patients as inpatients for this treatment. Most patients tolerate the treatment very well indeed and don't require hospital admission, thankfully. So you will come to us once a day to receive your radiation treatment. You'll come and visit our lovely waiting room downstairs and hang around for a little bit. Sometimes it can be running a little bit late, as I'm sure some of you will know who've been through. Sometimes it's not entirely our fault, where it's the machine has wobbles and doesn't always like to deliver the treatment. So we occasionally have to apologise for the delay, and you might have a short wait whilst you wait. But anyway, so yeah, you come every day, Monday to Friday. We generally don't treat at the weekends, although that being said, generally around once a month the machine has a big wobble, and we do sometimes need to do a Saturday catch-up. Or if the machine is on a long weekend service, we sometimes do a sliding week where we will treat you at a weekend. But for the main part, it's Monday to Friday. We generally give the treatment over a total of 41 treatments, so it's just 8 weeks and 1 day that you will be with us for. It sounds like an incredibly long period of time, and when patients start, they're like, oh, crikey, 8 weeks being here in Manchester. But it does go pretty quick. Once you get started on the treatment, you soon find you're a week in, then you're halfway, and then you're at the end. So it does seem to fly by. The treatment takes between 20 to 30 minutes each day to deliver, so we get you into the room, we'll lie you down on the couch and we'll pop your mask on, and then the staff will make sure that you're in the exact right position for your treatment. And it's really that process that takes the time up. The actual radiation itself is delivered in a matter of minutes, but physically getting you in, set up and moving the machine around you is what actually takes the time up. We will also do a weekly check-in with you, so it's usually on a Monday where you'll meet a member of the clinical team, so it might be myself, one of our clinical fellows, or it might be the consultant, and we will just take the time to check in with you, see how you're getting on and manage any toxicities that you're getting. So the accommodation, like I said, it's fully funded by the NHS, so that's NHS England, Wales or Scotland, and if you're from Ireland, unfortunately, it's not funded, so the accommodation does need to be self-funded if you are a patient from Ireland, unless you are a teenager and a young adult patient, so the ages of 16 to 24, in which case a charity will fund the accommodation for you. But outside of that, Irish patients do need to self-fund the accommodation. So our accommodation is located in the city centre of Manchester. It's right outside Manchester Piccadilly train station, and it's a lovely apartment, hotel called Stay City, and they are self-catering apartments that you are allocated. So as an adult, so if you're 25 or over, you're allocated a one-bedroom self-catering apartment. If you're a teenager and young adult, so 16 to 24, it's a two-bedroom apartment that you're allocated. All the linen and bedding and everything is provided for you, so the only things you need to bring are your own clothes and sustenance whilst you're with us. So in order to get you from the accommodation to Christie, because we are about 20 minutes south of the city centre, we have a shuttle bus service that rotates between the accommodation, Royal Manchester Children's Hospital and the Christie Proton Centre. So patients can just hop on and hop off that as and when they need to get here. So in terms of the support whilst you're actually here, so there is a team of us that have advanced skills and knowledge and can support patients going through the treatment. So, and like I said earlier, we are there from the initial point that you are referred into our MDT, so we know about you from very early on, and then we are really your main point of contact. So very much like Andrew is on the surgical side, we have pretty much the exact same role over here in radiotherapy. And we very much liaise with the referring centres as well as any of our AHP colleagues, which I'll come on to shortly. So every patient referred to us is allocated a specialist practitioner who is their named point of contact, and we support you right from the point you accepted MDT all the way through to that first follow-up and onwards for some patients as well. And yeah, we really enjoy our jobs and we take pride in looking after you holistically. So yes, you're here to have your chordoma treated, but we very much care about you as a person and you as an individual, and we hope that you feel that too when you come to and see us. So as well as having an allocated specialist, we also are very fortunate to have a team of allied health professionals that help and support our patients. I'm not going to go through them individually as to what they do. I'm sure you're all aware of the different AHPs and their specialities. But all of the professionals will provide baseline assessments for patients and then ongoing personalised plans for patients if they're needing it. So, for example, the speech and language therapist can help, and the dietetics can help and support if patients are developing mucositis or swallowing problems and need additional help with their intake. And then they also will liaise back with the referring teams as well. So if you are needing ongoing dietetic input, for example, they will ensure that that is followed through, so when you go home it doesn't all just fall off the cliff. As well as a host of clinical support for you whilst you're here, we are extremely fortunate to have a lot of non-clinical support too. So top of the list has to go to Maggie's, which is an absolutely fantastic resource. I don't know if any of you are aware of Maggie's or have used Maggie's if you've been through Christie's, but they are a fantastic resource for everything non-clinical. So they are highly specialised in providing emotional practical support as well as toxicities and support and social and relationship support as well. So basically anything that's non-clinical they can help you with, whether it's just simple advice on travel insurance if you want to go away, or whether it's more detailed conversations about how to talk to friends or family about your diagnosis and what it might mean. Maggies are there to help you every step of the way, and not just you as a patient, but your family and your friends as well. For our younger cohort of patients, we have Young Lives vs Cancer, which is a fantastic charity primarily involved in social work, but they also provide a home-from-home accommodation. So for patients that perhaps aren't eligible for the NHS accommodation, they fund and look after home-from-home accommodation. So we're fortunate to have Jack's House here in Manchester for patients to stay in. And again, they will link into teams locally as well to ensure that continuity of care. Our youth support coordinator, Angie, if you've ever been to Christie, you will have known Angie because she's unmissable. She walks around in green, she's got bleach blonde hair, she's a loud northern lass, and she is the life and soul of level 1, really. And she coordinates lots of social activities and all the fun things for all our younger patients. So whether it's pizza nights from Domino's, or whether it's activities such as going to the football or spa nights away, she gets all the fun side of the patient experience, really. And again, she provides a lot of support locally with referring teams, but also age-appropriate support and peer support as well for those patients too. So in summary, coming for Proton therapy involves attending for multiple appointments, but for one block of an assessment visit. There is a turnaround time of between 2 to 3 weeks, although this can be extended if required. You need to attend daily for 8 weeks and 1 day. I missed that off that slide then. The NHS does fund accommodation for you, and we provide a shuttle bus here in Manchester. I don't think that's the same for UCLH just because of the practicalities involved in getting around London, but we certainly provide it here at Christie for you. And then my final point is that we do provide, or I would like to think that we provide holistic care for you as patients. So it's not all about your tumour. Yes, you're here for that, but we take care of you as a person, as a whole. So yeah, so thank you very much for, I've got one more slide. Thank you.
Thanks, Charlotte. Next to talk is Peter Sandy, complementary therapist here at the Proton Beam Therapy Centre in the Christie. Peter, a senior complementary therapist for proton beam therapy, has been part of the Christie award-winning complementary health and wellbeing team since 2013. Qualified in clinical hypnotherapy since 2007, he supports patients undergoing chemotherapy, radiotherapy and proton beam therapy, offering integrative therapies such as hypnotherapy and aromatherapy to manage anxiety, pain and other issues. In 2023, he coordinated a study on the effectiveness of complementary therapy in PBT, enhancing future patient care. Peter.
Okay, so as you'll see, there's the Cowardly Lion from The Wizard of Oz. And if I'm being honest, I've something I'd like to admit, it's a bit embarrassing because my role as complementary therapist is to help patients to feel calm and relaxed and cope with difficult situations. Yet this talk has made me feel quite anxious, and I've been a bit of a tiz all week. So I wanted the Cowardly Lion there to kind of, represent how I've been feeling. Thankfully and usefully, I've got loads of colleagues who have been really helpful with this to help me face the fear a little bit, remember my resources, remember to breathe. My daughter, who's a drama student, I call her like a drama queen, to be honest. She has really helped as well. She said, Dad, you've just got to get on with it and stop being a wimp. So here we go. I'm going to get on with it now. So I'm going to talk to you about, I'm not sure how to make it go to the next slide.
Use the little point control.
This?
Yeah.
Oh, sorry.
Big arrow in the middle.
Thank you. There we go. I'm going to talk to you about complementary therapy at Protons. Throughout the hospital, we've actually got a team. I'm a member of the bigger team, and we do support our patients with regard to all the conventional kind of treatments that they have here. So patients coming for chemotherapy and radiotherapy and proton therapy, people having scans, cannulation, injections, whatever it might be, surgery, all these things that create huge anxiety for some people and huge challenges. We use complementary therapy approaches to help our patients to be able to manage that stress and to be able to help them with some of the side effects that they have, such as nausea, or help them in general with their well-being, so to improve their well-being. The types of therapy that we use in Protons is a blend. It's an integrative approach. So we do relaxation approaches. We do hypnotherapy that can really help people to step back and detangle from some of the stress that they've been having and find different ways to work through using their resources, and mindfulness, which is a great way of just helping to relieve anxiety and be more in the moment. Progressive muscle relaxation, we use the yellow star that you can see there to great effect, and we can use that in the MR scanner. We can use that with patients when they're having their treatments. Breathing techniques that help to slow the breathing down and get the oxygen in properly and trigger the parasympathetic nervous system to help the relaxation response increase. I've mentioned rapport building there, which obviously isn't directly a complementary therapy thing, but it's really important because when we come alongside patients, we often find them in a highly anxious state. And it's really important to make that connection and build that trust so that we can understand exactly what's going on, and then we can find, within the integrative approach, things that can really help them to manage their breathing, let's say, or to release some tension, or to find a resource that they have and then work through the situation. So there's lots of different approaches. All of them tend to have a relaxation element, because obviously that helps to reduce the stress, and it's good for the person to kind of step away from the constant kind of, people sometimes call it a roller coaster, of one clinic thing to the next thing, to an appointment, to a treatment. These sessions can often just really help them to step off that and have a bit of relief or a moment to recharge their batteries, which is often very, very useful. So look at this aromatherapy, beautiful oil there. We've got lots of different aromatherapies that we offer. But what I really like about aromatherapy, and what's really useful, is that it's very direct, because aromas go straight to the limbic system, and that's emotion and that's memory. And if we combine that with hypnotherapy approaches, what we can do is start to anchor a resourceful feeling or a place. So it might be somewhere very calm that we help them to engage with, and through relaxed breathing and through guided visualization, and we can kind of enhance and amplify that feeling to the point where it's really, really useful for them. And then we anchor the aroma, and when we do that, we can actually give them an aroma stick with that aroma on, so that when they're in treatment or when they're in the waiting area, they can often access that state again quite quickly. So it's really useful in lots of different ways, and the peppermint and lemon one is actually really nice, so I feel like we should sell that in a shop somewhere, but it does elevate mood. So some of the things that we get involved with, some of the common themes that patients really do struggle with. Claustrophobia is probably one of the most extreme ones. Claustrophobias can be triggered in the MRI scanner. They can be affected with the mask themselves, the immobilization mask, because it is so snug. And we can come alongside a patient, and if they're struggling, we can help them to find a way through, find a technique. We can even go into the MR scanner and sit with them whilst they're having their scans. And sometimes just having a person nearby, especially if you've made a good connection with that person, even if it might be quite brief, can make a big difference. So it can just give that person something that they need to get through that moment, and then we can get those scans and we can plan, or we can see what we need to see. Needle phobia is very common. Hospital phobia is sometimes here. We actually had a patient the other week who had a hospital phobia, and he was with us for quite some time. And I'll just give you an example. We used hypnotherapy to help him to work through the issue. We did a desensitization protocol, and he found a really useful relaxation technique. And before, because the hospital phobia had happened years ago, he couldn't even enter a hospital. He was okay in Protons, but he couldn't enter a normal hospital. And by the end of the sessions that we had, we were doing exposure therapy, and he was going into Christie's. And by the end of that treatment, he was able to actually go and collect his prescriptions by himself. And he was really surprised at, how useful that was for him. Anxiety and panic states. I'll give you another example. We had a Chordoma patient a few years ago who would have a panic attack actually in the gantry. And we talked a lot about this a lot, and it kind of really stemmed from the idea that his optic nerves were at risk of some dose, and he was obviously, rightfully worried about losing his vision, so he'd have a panic attack in situ. And so we worked on this quite a lot, and did hypnotherapy. We did a lot of relaxation work around it, which worked great in the time. And then when he went back in, he kept having the panic again, until we hit upon something that did work, which was a song, because you can be very creative with therapy. And the song was Don McLean, My Miss American Pie. So he'd have that, and he'd hum it, and he'd sing the words, and it really helped him to avoid that, well, not avoid, but lessen the reaction. So obviously there's lots of other things along the way, but we really don't have time, I feel, to go through everything. Health and well-being wise, we do help with smoking and alcohol cessation. And again, hypnotherapy is really good at helping people to manage stress and look at different ways of approaching problems. Another thing you might not be aware of, but we actually offer support for partners and family members, which is really useful. Quite often it will be the patient that will say, can you see my partner? They're doing my head in. They need some stress relief. And then we go from there. So it's another thing that we offer, but obviously it has a positive impact on the patient, and it's another holistic kind of approach to helping. Okay, so I think that's completed my talk. I just want people to realise the therapies are there in a way to help people to relax and cope with the stress of being here, and the stress of diagnosis, and the stress of all the different treatments, the side effects. There's certain things we can do that really help, and overall well-being as well. So just having someone that you can talk to, have a space that you can relax in, or feel how you maybe want to feel for a little while. So thank you very much for listening, and any questions later on? Okay.
Peter, thank you very much. Our final speaker this evening is Sylvie Leslie. Sylvie's a Chordoma patient, and she's also a trustee of Chordoma UK. Sylvie lives in Hertfordshire with her husband Drew, who's here this evening, and was diagnosed with clival chordoma back in 2017. She underwent surgery followed by proton therapy in the USA. Sylvie has since adapted to her new normal and is dedicated to supporting others with chordoma, especially in her role as the trustee of Chordoma UK. Sylvie, over to you.
Good evening, everyone. I could probably have done with some of Pete's treatment before coming here. So after an evening filled with insight from professional experts, so it's now my turn to share a different type of expertise, and that's through the perspective of a patient living with chordoma. So to give you some context, my journey with chordoma started unexpectedly in 2017. And I was just recovering from a stroke, which was caused by a congenital hole in my heart. And I was hit by another shock, and I was told that my MRI showed that I had a chordoma inside my head. I had obviously no idea what it was, and I asked the doctor to write it down so I could have a look at it later. So the doctor then told me it was something I had since I was a fetus, and which had been slowly growing inside my bones, and that I would need surgery and proton beam therapy would be necessary. So imagine hearing about a treatment that you've never heard of for a condition that you didn't even know existed. So I remember leaving that appointment feeling really numb and just confused. So how could I be dealing with this when I just had a stroke? And my mind was just racing, and I was like, how was I so unlucky to be so defective at birth, with a hole in my heart and a tumor in my head? So naturally, I turned to Dr. Google for answers, and then I got an even bigger shock, because chordoma wasn't just a tumor, it was a primary bone cancer. So my consultant had never mentioned the word cancer. So again, my mind went crazy, and my world turned upside down. And to make things worse, there was just so little information available online. So I contacted 3 of the major cancer charities in the UK, and sadly, none of them could help, as they never heard of the word chordoma either. I contacted my GP, and same thing, he didn't know what that was about. So I had really a feeling of being lost, and all around me was just the unknown, and it was pretty overwhelming, to be honest. But I then carried on, obviously, and spent most of 2017 in what I call the medical fog, blindly following my doctor's instruction, without questioning much, really, because they're the expert, right? So in May 2017, I had an endoscopic endonasal partial resection of the chordoma, followed by a CSF leak, lumbar puncture drainage, meningitis the following months, another serious infection in July. In August, I went back to close the hole in my heart. And then, as there was no Proton Center in the UK, I was sent to Jacksonville in Florida for 41 rounds of Proton from September to December 2017. So, quite ironically, I've always enjoyed traveling and discovering new places and different cultures. But there is always one place I've said that I really don't want to go, and that's America. So I think there was someone up there having a laugh, and they decided to send me 3 months in Florida. So going to America for my treatment was pretty daunting at first, as obviously we had no idea what was going on, and we're just going with the flow because that was what my doctor was saying. So at my first appointment at the Proton Center, I was really anxious, but I was submerged by warmth and kindness from the staff, and it just made everything better. We did notice that there was a waiting room, so to speak, but it wasn't really like a stereotypical hospital at all. For a start, there was purposely no access to the internet, and all the benches were just facing each other, so for people to actually talk to one another rather than being on their phone and waiting by themselves. And on that same day, my husband made a point of telling me that he had no intention of talking to anyone when I would be having my treatment, and he's just going to be bringing his tablet with all his pre-downloaded movie to watch during this time. Well, that didn't happen. He was constantly making new connections with people from all over the world whilst he was waiting for me to have my treatment. And even a few times I had to interrupt him and ask him, please, let's go home now. The treatment, it did take its toll on me, and I was really happy on the day that I got to ring the bell to signify that the treatment was over. That meant I could finally go home. And after returning from America, everything changed. Suddenly it felt that I was no longer a priority for the medical system. The bubble truly burst, and I started to experience quite a few post-Proton side effects, and I realized that I was on my own. I didn't have those great experts here today around me, and every time I was reaching out to a doctor, they would just be sending me from one to another all the time. So the message was pretty clear. My treatment was done, and now it was just a matter of lifelong MRI scan and deal with it. So that's when I kind of realized and understood that actually doctors saw me as a human body rather than a human being. So I then decided that I had to take control, and if no one could tell me what was going on, then I would need to find the information myself. So I spent sleepless nights researching chordoma and its treatment, educating myself about my condition. But more than anything, I really longed to speak with other UK patients who could actually relate to the healthcare system and the issue we're currently having. So in 2018, during yet another hospital stay, I had a chance encounter with a wonderful Macmillan representative who was here to visit the patient next to me. And whilst the patient went for scan, the lady turned to me and we got talking about the reason why I was here. She rightfully didn't know anything about chordoma, but she told me that she would take the time to find out about it. And sure enough, she came back the following day to tell me that she'd found Chordoma UK, a small charity which had just been recently created. So that connection was really a turning point for me. I did indeed reach out to Chordoma UK, but my timing wasn't great, as Suzanne, the co-founder with Gerald, was herself a chordoma patient who was not doing very well and sadly passed away in early 2018. But Gerald still took the time to guide me. His advice was to rest, focus on my recovery, and that resonated deeply as I was spending far too much time and too much energy on worrying and feeling unheard by the medical system. But over time, Gerald and we stayed in touch, and I watched as Chordoma UK blossomed, creating a private Facebook group in 2019 where patients and their loved one could finally connect and support each other. That group became a lifetime for me and for many others. We were now able to share stories, frustration, and triumphs. And it soon became clear that I wasn't alone in feeling forgotten by the medical world after treatment. It was a shared experience for many of us, unfortunately. On a personal level, I had quite a lot of post-Proton and post-stroke issues, and this meant that I wasn't able to do as much as I used to, so I had accepted and adopted a new normality in my day-to-day life, and I also learned to live with a ticking time bomb inside my head, going from one MRI to another. But thanks to my husband, being of Jamaican heritage, he has a very cool, calm and collected way of living and seeing life. So I've embraced his attitude, well, not all of it, and I learned to focus on what now, rather than what if. Because after all, we all know the words of the great Bob Marley, don't worry about the thing, because every little thing is going to be all right. Going through so much could have easily broken me down mentally, but I chose not to let it, and instead I focused my energy constructively, which is when I started looking deeply into the world of cancers and research. I was really devastated when I found out that there was so much injustice within different types of cancer, and the fact that chordoma, as part of bone cancers, was left out of most of the big cancers donation from events happening constantly all over the world. None of the big national cancer charities or governments are assisting financially on the research for chordoma. So the only way that new and improved treatments are and will be developed is only thanks to personal and direct donation to Chordoma UK. So there it was. This was going to be my calling. This was what I needed to focus my energy on. So I needed to focus on raising awareness on chordoma and find ways to constantly raise funds for chordoma so that research could take place. And by 2021, I was so driven to ensure that no one else would ever feel the isolation I once did. And with the never-ending support of Gerald, I started the first virtual support group for chordoma patients and their loved ones in the UK, which I've named Chordoma Chat and Cheers. I then went on to assisting other chordoma charities in other countries in starting their own virtual support group. And I have to say I'm incredibly proud that I've played a role in the global expansion, and I've created a group that we didn't actually know we needed. And in 2022, I had the privilege of becoming a trustee for Chordoma UK. And whilst this may be a voluntary role, it's probably the best and the most important treasured role I've ever had, as it's allowed me to give back in ways that I couldn't have imagined. What drives me now is to do as much as I can to constantly raise awareness on chordoma, raise funds to create fundraising opportunities, and show everyone that we can all do our part to make it happen. As Adrian mentioned before, with funds, there will be research. With research, there will be hope. And throughout this journey, I've learned the importance of advocating for myself, challenging doctors when necessary, and reminding them that while they do hold the medical knowledge, we, the patients, we are the ones who live with this condition every day. We, chordoma patients, we are the true experts of our lives. And understanding chordoma and its effect on each one of us is not something that's given to us. It's only thanks to events like this one tonight and to the people who are part of this community, patients, loved ones, and experts alike, that we can all get to understand and learn about our condition. So this is it from me. But before I go, I just wanted to thank you all once again, researchers, clinicians, chordoma warriors, supporters, those who are here in person or virtually. And together we are pushing forwards the knowledge of understanding of chordoma to ensure that no one has to face this journey alone, and that one day a cure will be found. Thank you.
Sylvie, thank you so much for your talk. It was quite empowering and quite emotional as well. And I think everyone else on the panel realises that actually the patients do have an awful lot to say and an awful lot to give and are very happy and prepared to do so. They just need to be asked. We have run a little bit behind time, but I'm sure we have got time to take, or I'm told we've got time to take one or two questions, if there are any questions here from the audience, to any member of our panel or any general questions. So the floor is yours, audience. Yes.
Okay. My MDT team advised me that there's no further surgery or radiation left for me, so I'm looking for what's next. I'm currently on a drug called pemetrexed, which I read about from the States, and my local team have put me on it, which is really good, and it's actually having an effect in reducing the tumour. But at some stage, that drug will probably stop working again. I've already had afatinib, I was on the trial on that. So this really is a question for, I guess, Dr. McFarlane and Professor Flanagan. These alternative medicines, these drugs that you're looking at, they're obviously in the laboratory, they're working, but when does that laboratory become something which you can inject in me to kill my tumour?
So who wants to answer that one? How long will it take to get these alternate therapies, these new medications?
Well, I'll start with that. So when you start to identify molecules that may potentially become a drug, there's a normal time frame or an accepted time frame that has to go through for development. So you have to take the first stage of the molecule we call a hit molecule. You have to then develop that hit molecule into a lead molecule. that lead molecule will have features that make it a better chance of becoming a drug. You then have to do a range of biological and biochemical tests to enable you to go to the regulators to get permission to then test, so for example, do basic animal testing, toxicology testing to make sure that that molecule's then safe to put into human beings, isn't going to have unwanted side effects. So most drug development programs go through that set process. You then get permission to enter into a clinical trial. So, for example, you've been on the afatinib trial that Sandra was involved in running. The process for taking a hit to a lead molecule would normally take about 2 to 3 years. Then you have about a year to a year and a half of toxicology, and then you can get into clinical trial. Because chordoma is such an unmet clinical need on the therapeutic side, it may be that there's an opportunity to get into patients more rapidly and to have a lower threshold of requirements to get through the regulatory thresholds that would be set. All that's then also tied in with financing, because to go through those stages, you're talking about 10 to 15 million pounds, probably as a baseline, prior to getting to clinical trials. So, for example, one of the reasons we and others in the United States have now taken this into the commercial setting, that's because that's where you can get the finance and raise the finance to get you through those stages. So from a hit molecule to lead molecule stage, which is the stage we're at, and we know other companies are at in the United States, that's going to take about, sort of the full process will be 2 to 3 years, and we're in that process. Then it depends very much on what the regulators would permit us to do as the lowest threshold to then go into patients. And how do you go into patients? We were just discussing this earlier with Omar. So do you have an oral delivery, an intravenous delivery, or can you potentially directly introduce it to the tumour, post-surgically or during surgery? Because that would enable you to get into to a patient to deliver a potential therapeutic much, much earlier. So I know that doesn't give you a specific date upon which we could deliver, but I hope it gives you an idea of the time frames that are involved in these processes. The repurposing, for example, the afatinib, the therapeutics that we're aiming to develop with brachyury has been very clearly defined as the sole major vulnerability in chordoma. So I really do believe, and Adrian can possibly expand on this, that this is the target that potentially will hit all chordoma cells. And I come back to that uniformity of the chordoma cells, unlike other solid tumours, where you should then be targeting all the cells within the chordoma. I don't know if that fully answers your question, but hopefully it'll give you some sort of guideline. So, Adrian, do you want to add to that at all? No? Okay.
Ramsey, thank you very much indeed. Are there any further questions from our audience? Lady over here? Oh.
Oh, right, okay. I thought I was getting a gift. A quick question for Professor Flanagan. Early in your presentation, you indicated that there was some evidence of heredity in chordomas. Yeah? Given that the volume, if you like, the number of people with the problem is relatively low, would it not be sensible to think about vetting the offspring of people with chordomas? You know, I realise that full-scale vetting would not be practical nor economical.
No, I think it's a fair point. I think that the hereditary component is exceptionally rare. And all of those that have been described to date have occurred at the base of skull. And they are particularly indolent, kind of low grade. And I think there probably is more, people are beginning to think that way. There is an issue, though, about screening families, because having discovered that brachyury was crucial in the disease, the American group, who had been studying chordoma for many years, found that brachyury, a genetic abnormality in brachyury, is abnormal in a handful of cases. Yeah. And in those families, you can check for the genetic abnormality. I'm not sure how often that has been done in the UK, but over the last few years, patients could have, it was genomic sequencing was available for everybody with chordoma, and therefore it could have been picked up. So, however, I can't remember the precise, I think it was 4 out of the 6 families had a genetic abnormality in chordoma. There are still, though, some families without a genetic abnormality, so it's not feasible to screen for them. It would be useful, though, to identify such families, so we could do those investigations to identify that genetic abnormality. I think today there is more awareness about hereditary disease, and therefore I think that particularly if a good family history would be the first place to start, so I'm sure that the doctors and the clinical nurse specialists are asking and get a very detailed history about anybody in their family, about brain tumors, and they could therefore think about screening for the brachyury gene. So it is a very good point that you've raised, and thank you. Yeah.
Thank you. Thank you, Adrian. I think we have a question from lady over here, which probably we have probably time for this one and perhaps one more before we need to skedaddle.
Thank you. Thank you all very much for very, very interesting presentations. My question is to Professor Omar, if I may ask you. You mentioned at the end of your talk about the importance of patients being involved in the future in their pathways for treatment. Have you had any thoughts about how you would do that?
I think the landscape in which we're working is very challenging at the moment. We're in a sort of financial crunch within the NHS. There's huge black holes everywhere. Specialist services were being created sort of around about 10 years ago, and there were a number of other rare conditions where very well-funded national highly specialised services were commissioned by the NHS, and that could involve involvement of patients as part of the process of creating that. Unfortunately, with the financial difficulties that have hit the NHS and everything else that you all know about, although there is still a strong desire and drive from those of us working within the system to improve the services for patients with rare conditions and rare cancers, there is no money to do it. And so part of the challenge is, and I'm circling back to your point, is that if we were to take your to gather the opinion, which I think would be the next best thing for us to do, we may not be able to easily deliver on what is asked of us by patients. But I think the point that I was trying to make is that there have been a huge number of meetings, certainly dozens, probably more, at the highest levels within the NHS about chordoma. And it's been recognised that surgery on this highly complex disease needed to be looked at and to be in some way potentially improved or at least organised. But I don't think that patients have been involved in that at any point. And I don't. It's really a question. I don't know how to do that, to be honest. I mean, it starts here. It starts with this conversation, and then I suppose from there, perhaps Chordoma UK can help with that.
Well, absolutely will. I mean, I think we've all heard and seen that patients really want to be engaged. They really are prepared to be engaged. They just need to be asked. And certainly when it comes to clinical trials, patients, their hands go up the whole time. We want to get involved. And I think where it comes to sort of treatment pathways, yes, patients and their families want to get involved. They need to be involved because it's them who are receiving this treatment and it's them whose quality of life is going to be affected. So I don't know if there should be any shyness or holding back from the medical communities or whoever's putting together the pathways in asking organisations such as Chordoma UK or other organisations in the UK for patient involvement. You'll have an awful lot of people say, yes, we want to be involved. So thank you for your answer, and I appreciate the frustrations you're going through as well, which everybody feels. I think we've got time for just one more question before we have to go. Oh, what are we going to hear?
2 questions from online.
Okay. Actually, we've got quite a few people with us virtually, wherever they may be, from the United States to France to Italy and all over the place. So, a couple of questions that have come in. Question here is probably for Omar or Gillian here. What are the treatment options for recurrence of skull-based tumour 3 years post-BP, post-proton beam therapy? It's quite a wide question, I know, and you can't answer specifically, but can we just give a short, sharp answer to that one question?
So I think, firstly to say, it is always a challenge in that scenario. There are no established salvage treatments which are, amazingly effective in this patient group, unfortunately, and I think this is where a combination of the multidisciplinary team giving individualized plan, but in addition involving clinical trial centres and partners around whichever country the patient happens to be in.
The answer is I don't know which country the patient's in, to be perfectly honest.
In some settings there is a role, although Jill will comment on this, for potentially considering for very specifically located recurrences further radiation treatment, but they are limited.
Yes, I appreciate you need a lot more information in order to answer that sort of question. Are there any other questions from the audience here? We can take one. Let's go to Clara at the top. Oh, you got the box. You got the box.
Is it on?
You can be our last question this evening.
Yeah, I think it might be for Professor Flanagan, although I'm not sure. Given that chordomas start in the embryo and are slow growing, and I think for a lot of people grow and present at such a varying age, is there any kind of research being done into how and when they present, and when they get to the point where they're needing surgery? And
the very brief answer is there is limited research. I think that any tumour that's growing very slowly is problematic, because actually patient doesn't wake up one morning and say, oh my God, I have a dreadful pain in my back. You've got a bit of a twinge and then it goes away, and then you think you go to your GP, but everybody over 50 has a pain in their back, or an awful lot of people. So how do you deal with that? We've just started to look at this in terms of, we've done a very large series of going back and identifying patients with these benign notochordal tumours. They're not biopsied anymore, so we've looked at them in radiology, but we've looked at hundreds of patients in the normal population. And I think if patients, we're in the process of publishing this, but I think if you see more than one benign notochordal tumour in a patient, they probably, in the future, we could possibly develop a pathway where they could be monitored more carefully. Because in the study we've done, there seems to be an association with, if you've got more than one, there's a greater chance of developing into chordoma. But it's very preliminary work, but it's something that we are pursuing.
Adrian, thank you very much indeed. I think if we have time, just one final question, because I know David Lee wanted to ask a question. So let's make this our very final question.
Hi there. I'll make this quick. What is the kind of most exciting development that you think of in the next few years that will benefit the community in terms of treatment, aftercare, anything that is exciting to you?
What excites you, ladies and gentlemen?
Well, I'll say I think that there's excitement on lots of elements of this. I think that the combination of really well-planned surgery in combination with proton beam therapy, I think and with centralization of these services, I think could really improve outcome for patients. And I think that is probably the more likely fast track to treatment, because that is, at the moment, the best chance of cure and treatment. I think the slightly more long-term is that I think that the work that Ramsey is doing on brachyuria, I think, is very exciting. I think there's so many people working on this at the moment that there will be, hopefully, some advance. And actually, I see that, you were talking about the minimal disease, that if you could, talking about it crudely, squirt a bit of anti-brachyuria when he's done your surgery, and you could get it in, that could be quite effective. But, the thing about research is you never know when you're going to find something really exciting, and that's why you have to keep going. And every bit of research is built on a previous bit of research. None of the research and clinical work that anybody has done is in isolation. It's the power of all of that together. So I think I am optimistic. We've come a long way from Dr. Virchow, who I showed you, the grandfather of pathology. Yeah. Yeah.
Adrian, thank you very much indeed.
But somebody else may.
I was about to say, if there are any other exciting things going on here which people want to talk about.
I think it's exactly as Adrian says. I think it's not a big bang we're looking for. We're looking for substantial, continuous improvement. It's that incremental gain that we will get by all of these things coming together that makes the difference. And I do think that actually the lowest hanging fruit, which is the least sexy bit, but is actually the organisation of care. And if we could get that right and get optimal treatment from what we have available now, then actually we would make probably the biggest bang that we can do with this disease in the next few years.
Omar, thanks very much indeed for your words. Well, I think that's about it, actually. Thank you all for being here this evening, both our live audience and those who have tuned in via our live stream, wherever you may be. It's been inspiring, empowering, interesting and educational. And I really want to thank each and every member of our panel this evening for their time here tonight. And I hope everybody found it particularly beneficial. I certainly did. So once again, if we can show our appreciation to all those who made this possible.